Okay. Good evening, everyone. Now we are starting a webinar of tonight. At the outset, I'd like to thank the CCI Core Committee, the Central Council, for allowing us to have this webinar, which will be 4 cases we'll be presenting today, one by one. The cases are mainly on interventions and infections, atypical infections and rare infections. We have 5 panelists tonight. Dr. Shreeja Nair from Navi, Mumbai, Dr. Narayan from Nepal, Dr. Deepak Muthreja from Nagpur, and Dr. Venkateswara Reddy Tummuru from Mahbubnagar. We have a radiology expert, a 5th panelist, Dr. Nikhil Gupta from Ludhiana, who will be helping us in various radiological diagnosis and differential diagnosis. So we will be starting our presentations tonight. Before we start our presentations, I would like to give special thanks to Dr. N.H. Krishna, Dr. Narayan Pradeep, my dear Dr. Ashish Dubey, Dr. Anil Maske, Dr. Vijay, who have been taking painless efforts to have these academic feasts across the country and taken pulmonology to the next level. All the CCI Central Council members, hats off to you guys. You have been doing a great work. And now I request my audio-visual team to start the 4 presentations, which we'll be having one by one. We'll have 4 cases. We'll be having all the cases one by one without any break. And at the end of it, we'll have question-answer session. Each case presentation will be about 10 minutes. So we expect that all the cases go over by 40-45 minutes. And after that, we'll start the question-answer session. I request our audio-visual team to start the presentation.
Good evening. I'm Dr. Shreeja Nair. First of all, before I start my presentation, I would like to thank Sushil sir and my fellow panelists. And I would like to give my thanks to Dr. Krishna sir and the CCI founder members for giving me this wonderful opportunity to present this case on the platform. So I'm Dr. Shreeja Nair. I'm Associate Professor in Department of Respiratory Medicine in MGM Medical College at Navi, Mumbai. So I'm presenting a case of skull-base osteomyelitis and acute otitis media with cavitary lung disease in an elderly male. So let's move to the history. So we have a 66-year-old gentleman who is actually a smoker and has been a diabetic since the past 25 years. In fact, his diabetes is not under control at all. He presented to us with trismus, difficulty in opening the mouth. He had frontal headache and drooping of eyelids and inability to close his eyelids since 1 month. He had history of discharge from both ears and was deaf bilaterally too. Patient was referred to us from the ENT department in view of an abnormal chest X-ray that they had done for PAC checkup. On probing further, we found that the patient has history of MDR tuberculosis in the past, more than 3 years ago, which was treated and cured in a different hospital. The salient points on examination, the patient had difficulty in speaking with trismus. On examination of the nose and the paranasal sinuses, we found nasal crusting, and there was pus discharge from bilateral ears. He had an upper motor neuron type facial nerve palsy. However, he wasn't in respiratory distress. In fact, his respiratory rate and his saturation SpO2 was normal. The chest examination suggested some bronchial breath sounds in the right intraclavicular region. He had mild wheeze as well in the right inter and the infrascapular region. So this is a pic of the patient. We can see that the patient has evidence of facial nerve palsy, upper motor neuron type. He had uncontrolled diabetes mellitus. His HbA1c was 12. He was HIV negative. The CT paranasal sinus and the temporal bone that was done here showed a bilateral acute mastocytitis with otitis media and erosion of the dural plate, which were signs of skull-base osteomyelitis. An MRI brain showed an inhomogeneously enhancing altered signal intensity involving the sphenoid sinus, which on discussion with the radiologist, it was told to us that it looks more inflammatory in nature rather than malignant. The HRCT chest was done after seeing the chest X-ray and to plan for further study, especially bronchoscopy. So this is the imaging of the brain. I will just run through this video. This is the CT of the temporal bone. and the sinuses. As we can see, basically it shows areas of sinusitis, especially destruction of the mastoid cells. And this MRI image shows there's destruction of the pterygoid and the sphenoid area. Basically, skull base. Evidence of osteomyelitis is seen in this MRI. This was a chest X-ray of the patient. As we can see, the right hila is pulled up. There's a bit of hyperinflation on the right lung. We can see linear fibrotic strands in the right and the left upper and mid zones. There is evidence of calcific nodules bilaterally, also areas of cystic areas in bilateral upper and mid zone. So the CT, I'll run through the CT video. As you can see, in the CT, there is evidence of right upper lobe fibrosis, and there's a dense, thick-walled cavity and bronchiectasis in the right upper zone. I'll pause it here. As you can see over here, we can see multiple nodules too in the right and the left upper lobe, as well as the left lingular region. Here, as we can see. So at the differential diagnosis we made at this point were the following. So first, we thought it could be a cavitary pneumonia, most likely due to an infection such as TB, fungus, or staph. Lung cancer was a possibility considering his age and his smoking history and, evidence of facial nerve palsy. Pulmonary vasculitis was lower down in our differential, but we thought of it because of the significant upper airway symptoms and findings. Collagen vascular disease, such as rheumatoid arthritis, was also a possibility because of the nodules in the lung. So we planned an FOB under general anesthesia for this patient because he had severe headache and sinusitis and crusting in the nasal passage. And also this, at the same sitting, the neurosurgeon and the ENT surgeon wanted to take, pus and biopsy from their sites too. So we did a bronchoscopy with TBLB, with BAL and TBLB. This is a small snippet of the video, which is showing us, this is the BAL from the right upper lobe, the anterior segment. We can see that the mucosa is highly inflamed. There's mucosal pitting, evidence of chronic disease. And from the right up in the posterior division of the right upper lobe, as well as the lower basal segments and the superior segment of the lower lobe, you will see soon, there was a thick, this is the right upper lobe we can see over here, the 3 openings. And now you see this thick caseous material, a purulent caseous material coming out from the right lower lobe. And this small video here that I want to show you is basically what the neurosurgeons did. They went through the nasopharynx area and put a catheter through to the area of the sphenoid sinus and took out some pus and took a biopsy from that region. So what were the results? Now the BAL came positive on culture for Aspergillus fumigatus within a week. It was positive for Mycobacterium tuberculosis on AFB smear as well as CB-NAT and line probe assay. Line probe assay also told us that the BAL was INH resistant. So it was a monodrug resistant TB. It was fluoroquinolone sensitive, but INH resistant. It also grew a significant growth of E. coli, which was resistant to fluoroquinolones, but sensitive to cephalosporins. The TBLB specimen that we took from the right upper lobe anterior in the apical segment showed some chronic granulomatous inflammation and branching septate hyphae that was suggestive of Aspergillus species. However, there was no tissue or angioinvasion noted in the TBLB specimen. So this slide shows us on the left the TBLB specimen showing the septate branching hyphae of Aspergillus. This is the Sabarot's dextrose agar showing us the growth of Aspergillus fumigatus. And on the extreme right, we have acid-fast bacilli seen on the ZN smear of the BAL specimen. And the pus from the nasopharynx as well as the middle ear also grew E. coli and Candida albicans, although Gene Expert was negative in that. We could not send any further tests such as galactomannan assays, beta-D glucon, or a specific IgG to Aspergillus fumigatus for this patient, as it wasn't done in our medical college and the patient couldn't afford it to be sent outside. As I said, the upper respiratory samples were negative for CB-NAT, but the biopsy from the nasopharyngeal region showed us granulomatous inflammation with areas of necrosis. Other important tests, the kidney function tests and the urine routine microscopy were normal, and ANCA was negative in this patient, so that ruled out vasculitis for us. There was no eosinophilia in the BAL or on the CBSE, which ruled out vasculitis or eosinophilic lung disease. The RA factor, ANA, anti-CCP were negative, so rheumatoid arthritis was ruled out, and there was no evidence of malignant cells seen in the TBLB or the BAL, so we ruled out lung cancer with this test. So the final diagnosis we made for this patient was INH-resistant pulmonary TB, chronic cavitary pulmonary aspergillosis or CPA, ASOM and sinusitis, which was due to E. coli and candidiasis, and possibly MTB infection in view of the lung TB. And he also had skull base osteomyelitis, which could be, due to disseminated tuberculosis. What was the treatment we gave? We started antitubercular treatment for INH monoresistance with rifampicin, ethambutol, pyrazinamide, and levofloxacin, which will be given for 6 to 9 months as per the PMDT guidelines of 2021. Antifungals were started IV voriconazole, followed by oral voriconazole, which will have to be given for at least 6 months or longer. While the patient was in the hospital, we gave him IV cefoperazone for the E. coli ASOM, as well as the BAL report which showed growth of E. coli. Surgical intervention was done by the ENT and neurosurgery team for ASOM and mastitis and sinusitis. Our patient is improving slowly but steadily, and we may consider right upper lobectomy at a later date after discussion with the thoracic surgeon, maybe after 3 to 6 months. So quick discussion. We know from literature that there's coexistent TB and aspergillosis in about 15% of the population in Asian countries. This is taken from a recent meta-analysis by Hosseini et al. In 2020. Chronic immunosuppression, such as diabetes mellitus longstanding, can mask symptoms of TB and fungal co-infection. And so we need a thorough workup for such patients with a bronchoalveolar lavage plus minus biopsy for diagnosing pulmonary aspergillosis. Combined treatment with antifungals and ATT can be challenging in such patients due to their age, due to drug interactions, adverse drug effects of drugs, and poor compliance. And close follow-up and interdisciplinary management in such cases help in quick diagnosis and management of such patients. Thank you for the patient listening.
Professor Dr. Thank you very much, Dr. Sushil Jain, for moderating this session, and especially thanks to our CCI Trustee Chairman, Dr. N.H. Krishna sir, and Pradeepa Narayan, and obviously the acting President, Dr. Anil Maske, Dr. Dubey sir, and the General Secretary, Dr. Anil Maske. I'm really very thankful to you all for giving me an opportunity to talk about atypical infections at high altitude at Himalayas. So the term atypical pneumonia was introduced many decades ago to describe unusual clinical presentations of pulmonary infection for which a specific causative organism was not recognized. Now, researchers have usually considered bacteria as being atypical if they are hard to detect through a standard bacterial method. And these atypical bacteria include Chlamydia pneumonia, Chlamydia psittaci, Legionella pneumophilia, Mycoplasma pneumonia, several viruses. And obviously the inflammation is confirmed or interstitial spaces between alveoli. Radiologically gives appearance to reticulonodular pattern, linear thread-like opacity in the lungs. Now, I'm going to present about our case, which appeared in our hospital, and the patient presented with high grade of fever, cough, shortness of breath, and as usual in Nepal, he has also had history of chronic alcohol and smoking for last 6 years. On examination, patient was semi-conscious, disoriented, tachypnoic, and cyanosed. And at the presentation, his vital signs were blood pressure was 90/60 mm of Hg, SpO2 was 76% at room temperature, heart rate was 124, temperature 103.2 degree Fahrenheit, and GCS was dropping. The EBM was eye opening was 3, verbal response was 3, motor response 4, and chest were bilateral crepitations and bronchi were there, and cardiovascular status seems to be normal, and per abdominal was soft. Now we went through the investigations. Total CBC was done. Total leukocytes count were 5,600, and differential count neutrophil 26, and lymphocytes were 71, and platelets were 1,20,000. Hemoglobin 16.3 at the presentation, and random blood sugar was 204 milligram per deciliter. RFT seems to be normal. Urea 27, creatinine 1.0, sodium 137, potassium 3.9, and LFT bilirubin was 0.4, and direct bilirubin was 0.2, and SGOT was raised. Obviously, it was 726, and SGPT 582. Alkaline phosphatase was 139. We did ABG also for that patient, and ABG showed pH 6.891, PCO2 101.9, PO2 34, and bicarbonate was 19.1, and lactate was 5.08. It shows the severe respiratory acidosis. USG abdomen was done, and it showed fatty changes in liver, minimum free fluid in abdominal cavity, and excessive underlying bowel gases. We went for the viral markers. COVID-19 PCR was done. It was negative, and also serological markers were also sent. HIV was negative, BDRL and HBsAg was also negative. We sent for a sputum profile. The sputum profile turns to be AFB negative and QoS negative. And HRCT of chest was also done, and it shows the subsegmental collapse, consolidation in the posterior segment of bilateral upper lobes of lungs, patchy and collapsed multiple nodular opacities in bilateral lower lobes with centrilobular ground glass opacities in remaining lungs. Peri-aspirated related changes or atypical pneumonia, a differential diagnosis. There were so many differential diagnoses. One of them was fat embolism syndrome also. Patient was very sick, GCS was dropping, blood pressure was getting down. So patient was intubated in synchronized mechanical ventilation mode. Under FiO2 was kept 100%, tidal volume was kept at 350, PEEP was attained, and rate was kept up to 14. As the blood pressure started dropping, we started inotropes, noradrenaline, and vasopressin was started simultaneously. Broad spectrum antibiotic was also started immediately. And IV fluids, considering the echo, we were allowed to permit 4 pint of fluids, and we maintained the electrolyte imbalance. Input output was well maintained. After 1 day, patient got really very sick, and patient went on acetol, and CPR was given, but suddenly we could not save the patient. Now once again, this was a really very difficult case for us to diagnose whether the diagnosis was missing or something else. At last, we concluded the diagnosis as atypical pneumonia, as looking after the CT findings and the total counts, and all the scenario was looked at, and we came to the final diagnosis that the patient was diagnosed as atypical pneumonia. Thank you. Later on, we will discuss about question answer session. Thank you, sir.
Good evening, all. I'm Dr. Deepak Muthreja. I'm a consultant interventional pulmonologist from Nagpur. So, first of all, I thank CCI to give me this opportunity to speak in this forum. and to invite me again in this webinar. Today, the theme is Pandora box or mystery cases. So I would, yes, the today's case, what I'm going to present is actually very relevant to this Pandora box, that is box of troubles. So I'm going to present this case of Contarani syndrome, which is actually bilateral effusion with different etiologies. So a 70-year-old female who came to us presented with coughs in 6 months, breathlessness in 6 months. The patient was already diagnosed with pleuropericardial effusion, for which she was thoroughly evaluated. Both the pleural fluids, pericardial fluids, everything was sent for investigations where these were exudative fluids, ADA was negative, it was negative for malignant cells. Even blood parameters like CA, enolase were negative. They have done a PET CT, which was also inconclusive. Then this patient had a past history of being operated for CA breast, where chemotherapy and radiotherapy were given to this patient, and also this patient was already on tamoxifen because ER was positive. This patient then was started on AKT with steroid, by which the patient improved significantly, but after stopping AKT and steroids, this patient again became symptomatic. Now, when she came down to us, she was anemic, ANA, anti-CCP, RA factor, all the blood markers regarding the autoimmune disorders were negative. We did a CT chest, and this CT chest was suggestive of left-sided moderate effusion with right mild effusion and a little bit of pericardial effusion. We did a 2D echo of this patient where the pericardial fluid was not tappable. We planned to go for a thoracoscopic procedure since the fluid was indeterminate. And when we did a thoracoscopy, this was the picture. As we can see, the fluid was hemorrhagic, and the pleural, the costal pleura was showing multiple nodules, and also there was areas of neovascularization. We did many biopsies and we sent it for histopathological analysis. This is, I'm just showing one, taking only one piece. This is because there's paucity of time. So we took one piece from this area, and from neovascularization area also we took multiple pieces. As we can see, there are certain areas which are showing a little bit of angiogenesis. So we sent this for histopathology. The report, sorry for a little bit blurred nature of the report, but it showed marked mesothelial hyperplasia and chronic inflammatory features. There was unequivocal evidence of tuberculosis and malignancies on the biopsy. We also sent this pleural fluid for cytology cell block. This was only mesothelial cells, lymphocytes, and polymorphs. But when we did culture of this pleural biopsy, it grew Klebsiella, which was sensitive to piperacillin, tazobactam, levofloxacin, and netlimycin. This patient was treated with antibiotics. Now, left-sided effusion got better. Patient symptomatically improved. But after 15 days, this patient developed breathlessness again and came to us with severe breathlessness. Breathlessness was actually so much, and the X-ray was not showing much of effusion. The D-dimer was 3683 since patient was having history of previous CA breast. We thought of embolism. We did a CTPA. The CTPA revealed that it was more of right-sided effusion now, and left-sided it was only mild effusion without any, the pulmonary arteries were fine. So we decided to evaluate her further. This was the CTPA report, which showed moderate right-sided and mild left-sided effusion with underlying segmental and subsegmental collapse. Facial effusion was also noted. So now what? We also sent this, we inserted a right ICD and we sent fluid for evaluation. Then we inserted ICD because patient was way too symptomatic. So we saw that it was exudative effusion. Again, it was lymphocytic rich, and there were some large mononucleosis, like 15%. The cytology cell block of this fluid showed atypical cells with suspicious features when it was more in favor of mesothelial reaction than carcinoma. We had a word with our pathologist. He told it's more of mesothelial reaction, and there was no evidence of like there are carcinoma cells, prime carcinoma cells were not there. What to do now? We were in a situation where we were about to think whether to go for a right-sided thoracoscopy again. Already we have done a left-sided, now right-sided thoracoscopy. Patient's relatives were not very keen on going for a thoracoscopy procedure again. So just we had our discussion again. I had a discussion with my pathologist that whether to send this sample for immunohistochemistry or not. After a consensus with discussing it with not many pathologists, we sent this block for immunohistochemistry. This was the immunohistochemistry report, which showed that GATA3 and hemoglobin were positive. These are actually markers of the CA breast. So this patient already had right-sided effusion, which was malignant, and left-side effusion, which was actually empyema. Then again, the patient was sent back to medical oncologist, where he started treatment of this patient. Unfortunately, we lost this patient because of the serious septicemia, which she developed post-chemotherapy. And the purpose of presenting this case is that we should always have a high degree of suspicion whenever we are dealing with patients who are already treated for malignancies. And we should always try to make a algorithm for their treatment and also for their diagnosis. And we should always be keen on finding any evidence for labeling them as malignancy, and we should not start AKT or any other therapy empirically. And mind it, this patient was recommended to go for a pleurodesis before they reach us, but had it pleurodesis being done from on the left side, this patient already had Klebsiella. It would have been devastated. Empyema must have been, the patient might have got severe empyema because of that. So we should be very cautious. We should always practice evidence-based medicine, and we should try to find out any kind of evidence whenever we are treating a patient with bilateral exudatory effusion. I thank you again for your patience listening, and I thank CCI for giving me this opportunity, and I'm open to questions.
So myself, Dr. Venkateswara Reddy, Tummuru, Professor of Pulmonary Medicine, SVS Medical College, Mahbubnagar, Telangana. First of all, I would like to thank CCI for giving me this wonderful opportunity to talk on foreign body removals, mainly in a pediatric age group with rigid bronchoscope. See, without wasting time, I want to start, and I want to thank my gurus for training me and supporting me and teaching me everything. Regarding introduction and all, everyone knows. Just directly, I wanted to go into the case scenarios. First one is custard apple seed. A 12-month-old baby was brought to emergency room in severe respiratory distress. Mother reporting that the child was seen playing with custard apple seeds. Baby was noted to have, on examination, baby was noted to have decreased movements in the right hemithorax, and baby was having tachypnea and tachycardia. On chest X-ray, there is complete opacity on right side, collapse of the right total lung. So CT has taken, which is supportive of obstruction at the right main stem bronchus. Then taken to OT, did rigid bronchoscopy, and initially we used to do everything with peanut optical forceps only. A retrieval done with peanut optical forceps. But the most important thing is the custard apple seeds and all better to do with alligator forceps. So in this case, we did with peanut forceps only and successfully retrieved. See, in the second case, you can see we have used alligator forceps. See, alligator forceps gives more comfort holding the foreign body properly from all the sides and retrieving without any problem. So in this, we have used alligator forceps. custard apple seeds is retrieved. And the second case is red gram. This is very small baby, a 9-month-old baby presented with difficulty in breathing, cough, and shortness of breath with high-grade fever. Saturation at room air was 42%. Chest X-ray was suggestive of left-sided pneumothorax. And CT, in spite of low saturation and all, by supplementing high-flow oxygen, we have taken the baby to CT. CT suggestive of obstruction of the left main bronchus with pneumothorax and pneumomediastinum. There was a lot of discussion regarding what to do, whether to go for ICD or not, what to do to go for bronchoscopy. We have discussed everything with anesthetist. We have discussed everything with patient attendants and all. So finally, we wanted to go for foreign body retrieval by keeping ICD everything ready in the OT. So we did rigid bronchoscopy. Directly, we intubated the baby with 3.5 number rigid barrel. Retrieved with optical peanut forceps. See, after retrieval only, we could be able to see make it out that is red gram. Initially, we don't know what it is. Finally, it was very difficult to hold the foreign body because of lot of secretions were there, because saturation was falling and all. Luckily, foreign body is out, which is proved to be red gram. And after that, baby improved with oxygen itself. We have not placed ICD, and we have not, and we saved the baby by removing the foreign body itself. And the third case is coconut chunk. In this case, the baby age was a 3-year-old baby brought to emergency room with complaints of fever since 3 days. Patient's mother reported that the child had consumed chunks of coconut 2 weeks back, and post which the child had severe cough. The cough subsided after giving a few percussions over the back, and they have taken to some local doctor. He has given nebulization. Child was given course of antibiotics before presenting to our ER. And on auscultation, there is diminished breath sounds on the right hemithorax. In memory area and interscapular and infrascapular area. On chest radiograph was within normal limits. We told everything with patient attendants better to go for bronchoscopy. Then they agreed to go for bronchoscopy. Fiber optic bronchoscopy revealed the foreign body lodged in the right main bronchus with copious amount of secretions. You can see there is left main bronchus is okay, right main bronchus there is obstruction with lot of secretions. Then rigid bronchoscopy performed with 4 number tube and retrieved with optical forceps itself. But the thing is, it is very difficult to hold the foreign body because of copious amount of secretions and all. By doing suction 5 to 6 times, then be able to visualize the foreign body properly and retrieved with peanut optical forceps. And it took 3 to 4 minutes to hold it properly and to take it out. But finally went well, and once it slipped down at the level of the carina and causing desaturation, but finally it is out. You can see coconut chunk. And one more case of plastic toy. A 13-month-old baby was brought to ER in severe respiratory distress. On examination, baby was found to be grunting. The mother reported that baby consumed jumps, small chocolates, while playing with plastic toys 36 hours before presenting to the hospital. Mother has not seen what baby kept in his mouth. Baby also had one episode of vomiting. On examination, saturation was around 92% at room air with tachycardia. On auscultation, there is bilateral polyphonic wheeze in the all areas. Chest X-ray was within normal limits. See, we counseled the parents regarding need of CT scan and bronchoscopy, but they are like, if you are suspecting foreign body anyway, you have to remove it, go for bronchoscopy directly. We did fiber optic bronchoscopy first. It was showing a plastic foreign body in the trachea, which is moving in and out. We can see that it is moving in and out. On rigid bronchoscopy, a plastic then intubated with rigid bronchoscopy, because we were not sure whether it is only plastic toy or there may be chances of chocolate also inside the airway. See, you can see that foreign body is moving in and out with each inspiration and expiration. See, try to remove with rigid optical forceps. See, we tried to remove by holding the foreign body at the top, but it was so slippery, it was not coming out. And at one time, it felt me that some obstruction at the lower end also, because of that only the foreign body is not coming out. I tried to hold the foreign body at the top initially, but unable to hold it properly. So what I did, I have passed the forceps down and hold it at the center and removed it out. In this attempt also, I was unable to remove in this attempt also. So I tried to hold it in the top again, but unable to remove. So this time I have passed the forceps down and holded the foreign body at the center, and I took it out. See, we can see that hook was in the downer side, so that most probably that hook was obstructing with or holding the mucosa. That's why unable to retrieve when I was holding the foreign body at the top. So these are the only few cases just I wanted to show you. And if there are any questions, I'm happy to answer. And again, once again, I am thankful to CCI for giving me this wonderful opportunity. Thank you.
A very good evening to everyone. Now again we are live, and we'll now have the question answer sessions. We will have the question answers case by case. First we'll start with the first case, the question answers for the first case, then second, third and fourth. We'll go one by one so that the sequence is maintained and we are able to discuss in a proper way. To start with the first case by Dr. Shreeja Nair.
Yes.
Any questions from the panelists regarding our first case by Dr. Shreeja?
Yeah. Hi, Dr. Deepak here. Dr. Shreeja, it was an excellent presentation. Post-COVID, we are seeing many such cases with multiple infections, not only TB, but fungal and two fungals also together.
Great.
So in this patient, you mentioned in your presentation that you didn't go for beta-D-glucan and galactomannan. So can you explain what benefit would have been got if we would have done this beta-2-glucan or a galactomannan, and also whether bile galactomannan or a blood galactomannan, the importance of both of them?
Yes, thank you, Dr. Deepak. Thank you for your question, and thank you for the appreciation. Yes, so in our setup, it wasn't done because the assays are not done in our hospital and the patient couldn't afford to do it. But yes, these are adjunct tests to invasive mycosis and invasive aspergillosis. So in not just in our patient, but if we're suspecting invasive aspergillosis strongly in a patient, then we must definitely ask for the, the bile or the serum galactomannan. galactomannan assays are more sensitive and specific in bile samples as compared to serum samples. They have a sensitivity of about 85% and the specificity goes up to 95% or more. Whereas in the blood, the sensitivity of galactomannan is lower. It's about 60 to 80% as compared to the bile. Even CSF has a high, specificity and sensitivity. So especially in our patient, I feel where there was osteomyelitis and maybe cerebral involvement, it could have been a good adjunct tool. The only thing is it takes about 4 days for the report to come. So it's not an immediate test, but it is an adjunct and it has been, described in guidelines as one of the tests that we do use for invasive aspergillosis. Now, coming to 1,3-beta-D glucon, that is a test that is used in the diagnosis for invasive mycosis. So it comes positive in aspergillosis, in mucor, it may come positive. Basically, it's used in invasive candidiasis too. So again, we select the patient. So if a patient is, if your patient is toxic, is severely immunosuppressed, has hematological malignancies or is on long-term corticosteroids, has a history of transplant, stem cell transplant, or CD4 count in HIV less than 200. Such patients are candidates for doing these tests where you might find a high positivity rate. Again, beta-D glucon is not done in the bile as of now. It's done in serum, I believe. So serum has a high specificity of about 85 to 90%. So yes, for invasive mycosis, we can do both. Galactomannan is more sensitive and specific for
beta-D glucan can be done. Beta-D glucan, sorry to interrupt, it can be done in bile also. So we can do both.
Sir.
Normally, in post-COVID era, we were using it very often and it was really helping us to make early diagnosis of fungal infections. Especially after the second wave, we used to have a lot of patients with fungal infections and there we were doing it more often. So it can be done in bile also. Yeah.
It can be done well. Okay, sir. Sorry. But I haven't used it yet in BAL. So yeah. Thank you, sir, for correcting. So yeah, now, I hope I've answered.
Thank you. Yeah, it was really nice, Dr. Shreeja. You explained it very well. Any other questions from the panelists? Any other question we have?
So I'll ask the second question for you. This was well answered by you. So since you said that there were two infections together, like tuberculosis, which was INH monoresistance, right? And also there was aspergillosis. So you selected voriconazole. So whether voriconazole, you had any dose adjustment or shifting to a posaconazole would have been a better option because posaconazole pharmacokinetics are not through liver. Can you explain it, or other antifungals what have interaction with your anti-tuberculosis drugs? Because it is isoniazid monoresistance rifampicin, which is like a very good enzyme inducer. So if you can tell about that.
Yes, that is true. Actually, like you said, it's not voriconazole is not the perfect agent to be given with rifampicin because yes, there is cytochrome P450 induction, and it may reduce the levels of voriconazole. Posaconazole is not the first line agent for chronic pulmonary aspergillosis. We were not treating an invasive pulmonary aspergillosis. This is a chronic pulmonary aspergillosis. And I went through case reports in the past where, there are about 3 case reports from Mexico and one from India, 2 from AIIMS Nagpur, actually, a patient and CKD patient who was being treated. Voriconazole was used in most cases, maybe because of its easier availability. Posaconazole, like you said, the enzyme induction is less, but as per literature, even rifampicin causes metabolism through a glycoprotein efflux mechanism. That is why I've read. So even the levels of posaconazole are reduced when given with rifampicin. So I think in such patients, what we should be doing is monitoring the levels of voriconazole. The other options we could have had was use a salvage therapy with echinocandins or even use amphotericin B liposomal. But considering his age, the cost factor, the adverse effects of such drugs, we decide to go ahead with voriconazole, and we will be monitoring his blood levels and taking a call. Sir, if there's anything you would like to add, Sushil sir, regarding this.
Usually now the cost issue becomes a big factor for posaconazole because you don't have and you have to use it for a long term. So it's difficult to use posaconazole for such a long issue. Usually voriconazole is a relatively cheaper option. So that is usually done. In clinical practice, I think we most of the time use voriconazole, though I know that there are issues of drug interaction which are concerned. But in real world situations, I didn't found any major issue for us. In real world, we treated few cases and we were able to handle it with this, though I know theoretically there is an issue, but then we have to look at all the factors together. And when we treated patients, they did well. We had a case of fungal pneumonia with TB recently, and that patient also did well. We used voriconazole along with AKT, and I know practical issues are there, so need to still take care of it and still patient clinically respond. Any suggestion from Dr. Deepak? You want to suggest anything, or any other panelists? What you would do in this scenario?
As you rightly said, that cost is the biggest issue in this country, since the patient has to pay from his own pocket. And yes, we also had treated our patients with voriconazole only. I also had a similar patient who had tuberculosis along with aspergillosis. We also did with voriconazole. Yes, we didn't monitor the blood level, but yes, we monitored the patient very frequently, and we saw that both of them, after giving that 6 months of course, they responded quite well. Voriconazole is an option. Blood level
monitoring again is a difficult task. It's not a cheap option. The patient is already paying a huge amount of money. So again, how frequently you monitor blood levels, difficult to say. But what I have done in few cases where we have done it and we did well, and we didn't have any practical problems. The patient got cured. That's the most important thing. The patient got completely cured of the disease. So I believe we may still use it. Yes, if you have an option of using posaconazole, that's a good, or if you have an option of monitoring the blood levels, that is still fine. But again, in real world practice, sometimes it may become difficult for us to do that. And I think that's the way we move ahead in this particular scenario. Now, I would request our radiology expert, Dr. Nikhil Gupta from Ludhiana, to give his opinion regarding the CT scan, which we see in the first case. As a radiologist, what would be the differential diagnosis which comes to your mind that, okay, this is the possible DD? Because a lot of times the radiologists guide us or help us to make a diagnosis, and then we move ahead and select the specific investigation which would be required in that particular case. So radiology plays a major role, and I would really request Dr. Nikhil to please give his opinion about the findings of the CT scan and what differentials he will consider in the first case. Dr. Nikhil, please.
Good evening, everyone. Good evening, Dr. Sushil. It was a very nice presentation by Dr. Shreeja. And as she has discussed that the radiology, we could see
So would you like me to share the CT?
No, I have the CT. Yeah. A thick walled cavitary lesion in the right upper lobe, and multiple centrilobular nodules in the bilateral upper lobes. Also, there was dilated bronchi that could be seen. So the first diagnosis becomes likely infective. We can see because like cavitating like TB, fungal, and like other fungals like nocardia, etc. And invasive pulmonary aspergillosis could be considered, and chronic pulmonary aspergillosis could also be considered. These are the differential diagnosis. And
is there any way you can differentiate chronic pulmonary aspergillosis versus invasive on radiology? Is there any way, or no, we cannot? It's the clinical
chronic pulmonary aspergillosis. In this, there are one or multiple cavities with or without fungal ball or nodules on thoracic imaging. That direct evidence is, however, required.
Because most of the time it will be a clinical judgment whether it's an invasive
Clinical judgment for more than 3 months.
And chronic, usually they are a more slow process and the patients are not so sick. Whereas in invasive pulmonary aspergillosis, patient will be really sick and bad. So probably it's more of a clinical decision, I believe.
Yes,
So,
and also the aspergillosis, the invasive aspergillosis could be angioinvasive and chronic necrotizing type. So
that would be a radiological finding which can help us. Correct. Okay. Thank you, Dr. Nikhil. Now, Dr. Shreeja, one important thing I want to ask you. As we all know that the fungal cultures take a lot of time to come. And when the patient is sick, it's really difficult. It's important that we take an early decision. And so it's more of a clinical judgment when you start treatment with specific antifungals. But then there are certain, is there any new way by which we can make an early diagnosis and have a not only just clinical but some supportive evidence, because before starting antifungal we need some amount of supportive evidence to start with specific antifungal. They are very expensive drugs. We have to give it for 3 to 4 weeks or longer, and especially in invasive one. And if we have some more evidence, probably it will be easier for us to start the antifungals. So what are there any specific new tests available by which we can make early diagnosis of fungal infections in patients like this, what you presented?
So now we have panels of PCR, RT-PCR, real-time PCR, which detect, multiple fungus at the same time. And these reports, it can be done in the blood, it can be done in the bowel, sputum. They're quite sensitive. Before there was, nowadays the machines are calibrated and the process is more controlled. So these reports are given in 10 to 12 hours. You get the evidence that the DNA was detected of the fungus, and it can also give you a quantitative analysis of how much the load of the fungus is. This is one useful test, but of course cost again is an issue because these panels are usually somewhere between 10 to 15,000 for just the fungal part. And then the easiest way I would say, and the cheapest, would be to do a KOH mount, pap smear, HP, all these things on respiratory specimens. If you can give you the evidence of fungus. Yes, it might not be that sensitive and might not help you differentiate between fungus, but if you see a septate, branching hyphae without, any yeast cells budding, this could be aspergillus. Mucor will not have any septate hyphae. So these are the easiest and the quickest. I still would be to go back to our basis and do a KOH or a PAP or HP. Microbiology, yes. And so of course,
I agree with you that our microbiologists in our hospital, I remember they have diagnosed so many cases of fungal infections just on microscopy, and then later we proved it later. So during especially this all experience we had in the post-COVID era, when our microbiologist was really they were very keen and they were very helpful in making a diagnosis even before we get a galactomannan or beta-2-glucan or a PCR. Fortunately, we are lucky that we were able to do most of the tests. But what we realized that the microbiology was playing a very important role in early diagnosis. Smear examination, and we were doing bowel and sending it to microbiologists. Within 2 hours, we were getting an answer that, okay, this is a fungal infection and please go ahead. And they were also able to help us to decide which possible fungal infection was there on the basis of the morphology. So I think even these things are important, which we somehow neglect, and we don't involve our microbiologists so well. I think there was a close association with your microbiologist, a close discussion with them, and telling them what you are expecting makes a lot of difference. And then once you have done that, definitely other tests like a PCR, you rightly said PCR can be done, but again, they're fairly expensive. If you do a whole panel, it may come about 25,000 or more. So that's if you do because when you are doing a PCR, you just don't do fungal alone. You usually land up in doing more other, because usually they are co-infection. It cannot be just, fungal infection. Most of the time you land up in having co-infection. So you land up in doing a big complete panel, and then that's cost is a big issue there. So in resource limited settings, I believe microbiology, a good CT scan, reading of the CT scan can help you to decide to some extent the antifungal management and other antibiotics which are needed. So radiology and good microbiology can play a key role in making a specific or at least a close diagnosis and then treat the patient accordingly.
Yes.
Okay, so we move on. Any other question for Dr. Shreeja from our panelists, please? One more question from me, Dr. Shreeja. What are the other treatment options which we would be having if we are, for example, you are giving voriconazole here, but what are the other treatment options in patients of fungal infection, especially the invasive pulmonary aspergillosis? What are the other treatment options that are available apart from voriconazole? Can you share with our audience?
Yes, sir. So antifungals becomes the first line of treatment, and antifungals that we usually use, the first line treatment for chronic pulmonary aspergillosis or invasive pulmonary aspergillosis is IV voriconazole. Even CPA, we can even use itraconazole too. These become the first line. And then patients who cannot tolerate, who have too many side effects, liver enzymes, getting deranged, voriconazole even causes eye toxicity. So such patients, if the patient cannot tolerate the medications at all, we can think of salvage therapy with echinocandins, mainly micafungin or caspofungin, and of course liposomal amphotericin B, which used to be the first line years ago, but again, because of the toxicity, we prefer not to. Recently, there have been reports where for invasive aspergillosis, they have combined therapy. So they've used a voriconazole along with an echinocandin or an amphotericin B. So I suppose in very sick, toxic patients, this may be a trial. We can combine the antifungals. And other than that, there was a review, if you remember, way back in 2011, which was published on chronic and pulmonary aspergillosis in the ERS, ERJ 2011, which talked about even giving things like, immune boosting things such as granulocyte colony stimulating factor, interferon gamma. These may potentiate the neutrophil, activation that is basically improving the immunity of a patient. Although I don't think I haven't practiced any of that. And apart from the antifungals, I think what we have is surgical management. Now, surgical management for invasive pulmonary aspergillosis and chronic pulmonary aspergillosis is limited. But in cases where you have a solitary pulmonary nodule, solitary aspergilloma, and a patient is young, if a patient has been treated for chronic pulmonary cavitary disease, and for example, in our patient, if he was maybe 20, 30 years younger and had a good functional status, yes, we can consider if it's just an isolated cavity, having repeated symptoms, hemoptysis, such patients can be a good candidate for surgical resection, for lobectomy, segmentectomy. So, yeah.
I think surgery plays a very important role in sicker patients, especially the mucor cases. Surgery has a very important role to play. And a lot of time, lobectomy has salvaged patients in mucormycosis cases. Again, this is experienced more in a post-COVID era. So that's what we have learned, that in few cases who are very sick and had mucormycosis, we subjected the patient to surgery, lobectomy, and we was able to save those few patients, those very few numbers, but makes a lot of sense. Surgery has to be, surgical team need to be involved. And in these cases who are sicker, who have more of a localized disease, they may resect the lobe and the patient can improve with that. So that's, I think, now we move on to our second presentation. Thank you, Dr. Shreeja. We have really done a great job. Thank you. And now we move on to our second presentation by Dr. Narayan from Nepal. Excellent presentation, Ram. Really nice to listen from you. Now we have a few questions for you, but before we ask the question, I would need our input from Dr. Nikhil Gupta, again our expert, the radiologist who is here with us, will be helping us to tell us what are the radiological findings which we saw in your case and what would be his differential diagnosis, what will be his point of view in this particular situation. So let us listen to Dr. Nikhil Gupta. Dr. Nikhil, please.
Yeah, very nice presentation. Thank you, Dr. Sushil. Very nice presentation, Dr. Ram. First of all, as we saw that there was bilateral upper lobe subsegmental collapse consolidation and multiple GGOs in bilateral lower lobes. multiple GGOs in bilateral lower lobes. And the differential diagnosis in this case, first of all, we have to look for whether it is a lobar type of consolidation, because it looked like so. It was a segmental GGOs were seen in bilateral lower lobes, right? So first we have to look for a bulging fissure sign, which is generally seen in cases of Klebsiella, Pseudomonas, Streptococcus pneumoniae, and then we have to look for atypical viral in the COVID era, in the post-COVID era. Atypical viral is also gives peripheral GGOs like in this case, but the subsegmental collapse could not be explained. Then aspiration, though aspiration is typically unilateral, but in some cases, like in chronic aspirations, this could be a case, or this could be a lung contusion, as it was mentioned that there was a rib fracture. So focal lung contusions could also be there, or contusions or hemorrhages. Also, fat embolism given as a DD, yes, it can be there, but there should be a primary cause of fat embolism. And
so in this case, do you think the fat embolism was a important DD for your this particular case?
I don't think so, sir. It should have a long bone fracture or something. Some inciting factor should be there. It was a rib fracture, which could be minor. He was a chronic smoker, so it could be a cuff fracture also. And in this case, sir, atypical pneumonia looks like a better DD. Mostly, clinically, it could be bacterial or viral.
Okay. Thank you, Dr. Nikhil. Now, my question to Dr. Ram. There are questions from the audience also. This is like, which investigations would have probably done, which would have helped in making a definitive diagnosis? And if you have the resources for doing it, I know that you are setting the resource limited, but then for the audience to understand that what are the other possible investigations would you have done to make a more definitive diagnosis and treated the patient better? So that's one question from the audience. Another thing which comes to is what would be the choice of initial empirical antibiotics which we're doing in this particular case scenario? So these are the two questions we want to know from you. Dr. Ram, please.
Okay, thank you, Dr. Sushil Jain, for the nice question. Actually, what happened that at that time we didn't have got the bronchoscopic unit that we would have done bronchoscopy at least, and have done the bulb. At least a bulb gave us some result whether, because all the reports were negative. AFB negative, serological markers negative, and PCR was also negative. So that obviously we could get the proper diagnosis after having the bowel of that patient. And regarding the other, we could have seen about whether that patient has having any systemic illness, for example, rheumatoid RA factor could have been checked like that, so that we can see the obliterating bronchiolitis or respiratory bronchiolitis could have been seen. And we did the PCR also, that came negative. And we thought about maybe this is during the COVID.
Which PCR you did? Which PCR you did?
COVID-19 PCR was done, sir.
Okay. Probably a PCR panel would have helped if it is available. I know that resources are limited, but I would say in case of resource available, where the resources are available, a PCR based, even a serum PCR test for which are available now, would have helped us. And BAL, definitely it would have helped us. We would have done a BAL and sent for investigation. Probably it would have helped us. Now the second question is, what would have been a choice of initial antimicrobial before you get all your reports? What would be your first choice of initial antimicrobial agent? That's because a lot of times there may be more than one organism. So the question from the audience is that what would be the initial antimicrobial agent you would select in this case?
After looking after the patient scenario, we started imipenem, sir, and also along with azithromycin, so that it would cover the macrolides, would help in this patient. Imipenem, broad spectrum, that patient gram positive and gram. Obviously, we gave the steroids. Methylprednisolone was given, and low molecular weight heparin was also given. And patient was sick, and patient was intubated, and patient was under the ventilator. Considering the situation, whether this one is the PCR negative, maybe this one is the COVID also, we started in the line of ARDS also, sir, to treat that patient. We kept the low titer volume, and PEEP was raised from 10 to 15, and rate was 14, so that we started treating in this way, sir.
Okay. Any inputs from the panelists about what choice of antibiotic you would have considered, Dr. Deepak? Any input from you? What choice of antibiotic you would have considered in this particular case?
Sir, that depends on what kind of microbial flora you are finding very frequently in your setup or in your city, or what kind of. So we always tend to have a discussion with the microbiologist, what kind of samples they are getting, and we choose antibiotics accordingly.
Yeah. So I agree with, but the usual, any broad spectrum to start with, initial empirical, what would have been a choice? What are the...
Sir, I normally, since we had a discussion with Dr. Nikhil Gupta as well, that it can be aspiration and these things. So I normally take with one carbapenem, and second one would be a clindamycin, which will take care of anaerobic, and one macrolide or doxycycline, which will take care of the atypicals. So this is what a combination, and later on, once we have our reports, we have that evidence of any kind of microbial flora, we de-escalate the antibiotics. This is what
I think, yes, I agree with you that initially hit high and hard and then de-escalate as per the culture reports. That would be the way forward. And one important thing is you have to look at your local flora which you are getting in your community and your micro. So we always do surveillance. We keep on reviewing our data of last 1 year or 6 months. We do it 6 monthly. That what are the organisms we are getting, and what is the sensitivity pattern for them, and that makes a lot of sense, and it helps you because the guidelines may not be appropriate for your local scenario. So even guidelines say that look at a local flora. So I very strongly believe that you should always review your local flora and what are the organisms you are getting in your culture samples in your lab in last 6 months or 1 year, and what is the sensitivity pattern, and what are the most of the organisms are sensitive, and then the choice of antibiotic probably would be according to that. I think that would be the appropriate way of doing it. Now another question for Dr. Ram. This is something. What is the role of steroids in severe pneumonia? That's a question from one of the audience. That and what would be the role of steroids, and what dose you prefer for steroids in patients of severe pneumonia that we consider as the case of severe pneumonia?
No, actually, we started patient to have a bilaterally bronchi, and cardiac seems to be normal. That we suspected whether there is the atypical pneumonia, regarding whether this is the viral pneumonia or something else. That's why we started with the methylprednisolone, sir, so that it can help the inflammation of the lungs, and there were little bit fluid in the lungs, so that it may help in the respiratory pattern.
I think for mainly for severe ARDS, you thought about severe ARDS. That's why you were thinking for the ARDS you were saying. So what dose of, so you prefer methylprednisolone or use
40 mg QID?
Okay, so that's what you use.
Methylprednisolone.
Okay, you don't use hydrocortisone or any other steroid. You prefer methylprednisolone?
they prefer methylprednisolone.
Okay. What is the choice of steroids from our panelists? Any choices of steroids you use? Dr. Shreeja, what steroid you use in ARDS or severe pneumonias? And what is the
prefer
dose?
hydrocortisone, either 100 TDS or 50 QID. So
50
100
QID,
TDS is usually started.
use it? Is that
So with 100,
50 QID
no,
steroid
100.
of hydrocortisone if you're using? Dr. Deepak?
So we usually use the 100 mg TDS. Hello. So I think the
Yes.
Hello.
Dr.
Sorry. Hello. Hello.
Yes, sir. We are audible.
you were audible.
I'm sorry. There was some problem with the internet connection. So what's the dose of steroid you use, Dr. Deepak, Shreeja, and Dr. Venkat?
Again,
So 100 mg TDS usually.
So
I'm using mostly prednisolone, that 1 mg per kg body weight. But again, I'll be very cautious while starting steroids. Need to rule out the bacterial infection. I tend to do first procalcitonin levels.
Okay.
This is what I'm following. I'm a little bit skeptical in using steroids because many times, under coverage of antibiotics, yes, you can give under what
septic shock dose, at least septic shock dose that you use. That's a proven thing.
Yes, that's proven, because that is also proven that infusion of hydrocortisone is also being given for septic shocks. That has a good,
Yes.
there was a paper regarding recent literature which showed that if you give it in as an infusion, it compensates for your adrenal insufficiencies, and you can use it. But again, it's like a word of caution for me.
Yes. Thank you. Now we move on to our third presentation, Dr. Deepak. Now again, you are back. So Dr. Deepak, there are quite a few questions for you. Now, the first question which comes to us is that why was D-dimer done in a case of pleural effusion? Normally we don't do it. So what was the specific reason you did D-dimer in a patient with pleural effusion?
Yes, firstly the D-dimer level was done when the patient started having breathlessness second time. First time the patient was treated with antibiotics after doing a thoracoscopy. After the patient did well, went home, came back again with severe breathlessness, and this time this patient was bedridden and also had a history of malignancy earlier. And the dyspnea was out of proportion to the effusion. Hence, we first did a D-dimer, as it has a very good high negative predictive value. We did this D-dimer level in this way.
And your D-dimers were high. How did you interpret that?
So now interpretation is that D-dimer is not having a good sensitivity for pulmonary embolism, but it has a negative predictive value, high negative predictive value. Hence, we subjected this patient for CTPA, CT pulmonary angiography. Because we thought that there can be some embolism. Yes, embolism are not causing a lot of effusion in the patients, but yes, one of the scenario which come across that some effusions, even exudative effusions, do have pulmonary embolism.
So that's exudative, but they are very small. Usually the effusion with P's are very small effusion.
Usually we don't get this much of effusion. Agreed. But again, it was just the high suspicion index. That's it.
Okay. And another important thing which we want to know is any role of tumor markers in pleural fluid. Any role of tumor markers in pleural fluid you would you suggest or you think should be done to make a diagnosis, especially in a case scenario when you already had a past history of malignancy and age was in your favor. I mean to say for malignancy, would you have considered tumor markers in pleural effusion?
Sir, there have been many case reports, or there have been many papers regarding the same. They have done like cytokeratin level, and they also have done CA in pleural effusions, but the sensitivity of them is very low. That goes from 40% to 57%. So normally they, now as we were discussing earlier, that we are in a resource limited kind of setup. Everyone, the patient doesn't need to spend again and again. So when doing these tests, it just add on to the cost, and thoracoscopic biopsy would have been preferred.
That's I think interesting because because you had a complicated case scenario, probably tumor markers would have helped to some extent because you were like not leading to a diagnosis. You were already doing a lot of investigation in this patient. You are
Yeah, yeah,
thinking of doing a thoracoscopy on the other side also. So that would be something interesting. And anyway, if you decided to do a medical thoracoscopy, yes, I think as an interventionalist, that would be the next step. But for the audience, we want to have your input. What are the indications for doing medical thoracoscopy? This is mainly for the PG students and for those who are at the early stage of the career. Which are the cases you would select for doing medical thoracoscopy? And what are the absolute indications and some relative indications for doing medical thoracoscopy?
Sir,
Dr. Deepak.
if I say in a broad way, the most important indication if there is a indeterminate pleural effusion. These are the indications where you are going to do a pleural
Exudative, not transitive.
Yeah, exudative.
Exudative, that will be very important.
Indeterminate exudative effusions. Yeah.
So exudative effusion, we don't have a definitive diagnosis, you would consider doing it. I agree with that. And sometimes we would also consider doing for early empymas. You do additional lysis with that. That's early empymas, maybe some cases, not the advanced one, and an indeterminate pleural effusion for diagnostic purpose. These are the thing I think major indications for all of us. And last but not the least, what would have been the sensitivity and specificity of cytology in pleural effusion and how you do it? Because their book says send 3 samples and then you send the whole thing. How you manage to do that? What do you think?
That is an excellent question. So now, if we say pleural fluid cytology, so if you do if you're sending the first sample that you are tapping for the first time, sensitivity goes to around 50%. Second sample, it goes to around 57%. And after third, it plateaus at 64%. Many times I've seen the young pulmonologists also and young physicians, what they do, every time they tap, they send for cytology cell block, they send for cytology cell block. After third, once you have to send the fluid for the third time for the examination, you play to the sensitivity pattern. After that,
do your patients have the patient for doing 3 samples, or they would run away? Probably.
Actually, when they come to us, sir, it's since it's our setup is like a tertiary setup. When they come to us, they have already gone through cytology 2 to 3 times.
Yeah, so agreed. But usually once or twice, if it is negative, we move ahead and go in practical situation.
Yes, in practical situation, we should do this. But if we go for
thoracoscopy. The literature, yes, that's what I'm asking. And do you send what amount of pleural fluid you send?
Again, it's a matter of what you call discussion. Why? Because once there was discussion that you send complete 1 liter of fluid, your pathologist is not going to see that complete 1 liter of fluid. So the best way is to either send the precipitate which is there in the fluid, and mind was one more thing is that you have to do it within 1 hour of tapping. You should send the sample and it should be centrifuged. When I had a discussion with my pathologist, she said that 100 ml of fluid is enough for doing a cytological examination, for doing a cell blocking.
But normally we are asked to send the whole sample and they will centrifuge, and theoretically it sounds good, but in real practice you usually send 50 or 100 ml of pleural fluid. You don't see send more in most of the cases. And one more question here has come, and that is a role of gene expert and FB culture. Is there any significant role in pleural effusions? In pleural effusion, I'm talking about not for sputum, not for pulmonary TB. Any role? Would you do a gene expert first thing on TB culture?
Sir, I don't prefer doing gene expert in the pleural fluid.
Agreed. Yeah.
One thing, because the thing is that there has been vast data about it, which range that sensitivity from 15%, 15 to 53%. So ranging if you take out the average, it comes around 40%, 40, and this test. Again, it is a costly test for the patients, and doing a biopsy, pleural biopsy gene expert is more sensitive and more specific than doing a pleural fluid gene expert.
But then you are doing a thoracoscopy in that case.
Yes,
If you're
yes,
doing a biopsy, you're doing a thoracoscopy.
Thoracoscopy,
So
yes.
probably a tissue gene expert and TB culture would have been a
Would
better
have
way
been a
of
better
looking.
option. Yeah.
Yeah, agreed. And TB cultures, how often you get positive in real world?
So there are very few.
Says 30%. Literature says 30%, if I'm not wrong.
Literature, yes.
Positivity. But
Again, different
do you really get it?
papers have sent different reports, but yes, it is quite low, sir.
Very low, probably in real world, the sense that we get very, very few. So though the literature is showing about 30%, probably that's what the literature shows, correct?
Yes.
But then real world, it hardly get positive cultures in pleural fluid. So maybe the take home message is, if you have undiagnosed pleural effusion, go for a medical thoracoscopy, do biopsy, send a tissue culture and tissue histopathology, culture and gene expert, all three in the tissue, you get a confirmatory diagnosis.
Perfect.
That would be the way forward. Agreed?
Yes.
All of us agree for that?
Yes, sir. Totally.
So now we move on to our fourth case. Hi, Dr. Venkat. You're prepared for your question. There are quite a few questions for you. Now, before we ask questions to you, first question to our to you and for our radiologists is, from the clinical perspective, when do you suspect a foreign body in a child, which would be important because suspicion is the first thing to start with. And what would be your first investigation you would do in a patient to have a suspected foreign body? I'm talking on mainly of the kids. So these are the two questions.
So most of the times, history is very important. If sometimes they may not see that baby has put something in his or her mouth. So if you don't know the history, then most important thing is only, most of the times they come with choking history only. If it is small foreign body, later they will come with fever, recurrent cough and all. Routinely we do chest x-rays, but most of the time chest x-rays will be normal. Then on clinical examination, if you are finding that there is absent breath sounds or diminished breath sounds and all, then by counseling the patients, most of the times we go for CT.
Okay.
But if they are, sometimes if they are strongly suspecting from family side and from clinical examination side also, by counseling the patients directly, in few cases we did directly flexible bronchoscopy also. But most important basic is chest X-ray and CT.
Okay. So you do CT routinely or you usually don't do it?
No, sir. We don't do routinely. But if few patients they ask, no, sir, first you go for CT, then only if there is strong suspicion of foreign body, then we directly go for bronchoscopy.
Practical problem we all face that even if you suspect, family wants to get a CT done before you put in a scope inside. So that's a practical problem. I think pressure from the family rather than your clinically you may be very strongly suspecting, but then sometimes you may have to do it. But most of the time you don't need it if you go by clinical sense. Most of the time it will be your clinical suspicion, a good history, examination finding, and sometimes X-ray. So that would be the first thing you, and most of the time your X-ray is the first test you do. And SOS if required, if really required, I may do a CT. Otherwise, most of the time you may be able to skip the CT scan if you have a good history and good clinical exam. So that would, and from Dr. Nikhil, what are the radiological findings you look for in a case of suspected foreign body? What is your input and what do you look at? What should a pulmonologist look at on your X-ray when you suspect a foreign body? What are the findings from your X-ray or a CT scan for that sake?
Most commonly, sir, generally it is lobar collapse or lung collapse, depending where the foreign body lodges. And mostly CT is helpful, better than X-ray, because foreign bodies could be like not of, obviously most of them are not radio opaque.
Okay.
And in some of these cases, MRI may also help.
So normally we don't do it.
Yeah, normally you don't.
We don't do it. MRI over.
In MRI, we can get artifacts of some kind. in the at the place of the foreign body. So it is helpful, and obviously CT is the best modality, routinely used.
Okay. But yes, in clinical practice, we may go history, a good physical examination, and an X-ray, and if required, maybe a CT scan. Agreed, Dr. Venkat? Another thing, which we have, the question which has come to you is, now, do you use rigid bronchoscope for all the foreign bodies, or you choose flexible, or both? Or how, what is it? How you do choose which foreign body, which scope you'll be using?
Sir, most of the times I use rigid because my anesthetist, he also says go for rigid.
Okay.
Because of good ventilation and all that comfort. And initially we got 2 to 3 bad experiences while removing with flexible. It got stuck up at the level of vocal cords and at the level of subglottic area. That time again we have to intubate the patient. We tried with LMA, but there are many cases we can do with flexible also. But the thing is better to do with rigid.
Okay, so your choice is rigid.
Yes,
now, a lot of people are moving towards flexible, and when we were discussing in World Congress this time, a lot of people were saying, like, of the opinion, those are the flexible favorers, I would put it that way. They say that majority of foreign bodies they can remove with flexible, but I believe that's like both complement each other, and whenever we remove foreign, whenever you are bodies, you should have at least, even if you are using flexible, you should have rigid standby, and it is should be available at the bedside, because when you need to convert, you don't know. So both, and you have to be, it has to be ready even if you are using flexible, because sometimes you are stuck, as you rightly said, especially at the vocal cord, it may just slip and go down again and obstruct the trachea, and then you may have to immediately convert. So you have, and larger foreign bodies for that sake. So yes, both complement, and those centers which are removing foreign bodies should have both the facility, and the people should be trained who are doing removing foreign bodies, because a lot of times it has been seen that people, they start doing a procedure because they want to start the procedure, and then they in a certain situation they really have trouble because they are not prepared for the worst case scenario. So one important aspect is you have to be prepared for the worst case scenario, and you need to think ready. Whenever we do a procedure in our unit, we see that everything is ready. We tell our team that what is our plan of action, how we are going, what we will do in case we don't have the, we are not able to remove with a flexible one. And we also keep all the tools ready in case of complication. So that's important. Good, all the accessories, the right tools need to be there at the bedside. And because what I have seen is sometimes you know how to remove it, but you don't have the right accessory. So it becomes trouble for you. It becomes difficult for you. You don't have the right scope. So again, that's important that we need to have all these things at bedside and be prepared for the worst case scenario. Now, one important question again comes to mind is that when you what types of scopes you would advise to the younger generation for removal of foreign body? What should be the setup available? Which is a minimum requirement to start the services for removing foreign body in your center? What would you say, Dr. Venkat?
Sir, you have answered this question just now only. So minimum requirements, it's not. It's like nothing, sir. You have to, based on the age of the patient. Most of the times we get around. One time I got 5 months old baby with chana inside baby's lungs. So that time I was not having any flexible bronchoscope. I have 2.8 with 1.2 working chart. I tried with that, but ventilating that baby was very difficult. Then immediately I have converted to 3.5 star scope and retrieved with peanut forceps. The thing is, see, minimum 2.8 flex. If you want to go for flexible, small size like 2.8 outer diameter with 1.2 working channel with basket, and rigid is 3.5 and 4 with optical forceps.
So rigid, you said 3.54.
Yes, sir, 3.54. And main thing is stars with 3 number tube, we don't get that optical forceps.
Forceps you don't have it. So 3.54 and 4.5 and 5, you not have the range, or you just want to have only these two? You are talking about the tubes you're talking about.
We use 5.5 also, sir, but most of the times 3.5 and 4 will do the job.
For smaller kids, it may be fine. Yeah, I agree. Okay, and the problem with you said 2.8 flexible scope, most of the accessories don't go well to the 1.2 channel. So that's the problem. You don't have accessories for that. So you land up with 4.2 or 4.5 flexible bronchoscope with 2 channel, because that's the minimum channel required for majority of the accessories. You need to have very special accessories for 1.2 channel. That's the trouble. So I have to really innovate and use accessories of other specialties, especially the urology guys. I have used their accessories because they pass through the ureteroscope. So I use their accessories. That's like you have to be innovative, because most of the accessories would not go through 1.2 channel of your flexible pediatric scope. And when you use distal foreign body, especially, it becomes difficult. Your rigid scope don't reach there. So you have to have a flexible scope, and that also with reasonable size accessory, which can be passed through through the channel of flexible scope. So that's again a trouble for you. Have to be really careful of selection of your scopes. I think 2.8 and 4 and at least 4 or 4.5 flexible scopes, and rigid scopes of say about 3.5, 4.5 and 5. These are the probably 4 tubes. And telescope you use 2.8 and 3 and 4. Telescope, which telescopes you use?
That stars one only, sir. That 2.8.
2.8 telescope.
Yes,
so
sir.
That's the only telescope you have?
Yes, sir.
Okay,
and
so
I have 3 also. Most of the times we use the 2.8 scope only.
Okay, and so that can go through your optical biopsy forceps. That can become 2.
Yes, sir.
Okay, I think most of the discussions we have done. Let me see if there are more questions for you. How do you manage foreign bodies which are there, chronic foreign bodies, of those who are there for a long time and a lot of granulation tissue around it? What do you do about them?
Sir, we get most of the cases of that kind only. If it is, it looks like more bleeding tendency and all, again, we'll place rigid barrel inside. Through that, we'll plug a flexible scope and we'll snare it. Sometimes. Snare it and, yeah, few cases we did. Only that granulation tissue, we have snared it and took it out. And sometimes we can remove.
Sorry, what you did?
Sir?
How do you remove the granulation tissue?
If there is large granulation tissue, if it is bleeding much, so I will snare. Snaring and removing steps or like that only. Or if it is not, there is not much bleeding, then with peanut forceps only, I will remove that granulation tissue. If there is mild bleeding with Fogarty balloon or cold saline, will do the job. Later, we'll remove the foreign body.
Now we have a little different experience on that. Now I have been removing foreign bodies from almost 15 plus years. What we do is I usually use for the granulation, we either use cautery or laser to ablate that granulation tissue, and then the foreign body get dislodged and we remove it. We removed a foreign body which was there I remember there was a nail which was inside the lower lobe bronchus with about almost a centimeter thick layer of granulation tissue above it. We made almost, you can say, laser drilling, you can call it. We almost gradually we drilled the whole lower lobe bronchus, and we drilled it through it. We reached the foreign body and we removed it. So we removed that way. We use laser. We use holmium laser. Why I use holmium? Because it's like doesn't go deep. It's a very superficial one. You have to gradually burn the granulation tissue, and you avoid damaging the surrounding tissue. and you can remove the foreign body even if it is deep seated. So again, that's something cautery or laser, or sometimes some people use cryo also for that. But I think cautery and laser are good enough in majority of patients. Bleeding is not there. It controls bleeding as well as burns the granulation. So both the things are done by that, and cautery is available with most of us. So cautery or laser can be used for burning the granulation tissue, and impacted foreign bodies can be removed. This can be a helpful tool in certain situations, especially impacted foreign bodies. And probably we are publishing one paper of use of holmium laser in impacted foreign bodies. Probably it will come in maybe in the next 3 months. We are publishing our paper. I have an experience about 10 years. I've been using it. More than 10 years. So we are publishing a paper of use of holmium laser in impacted foreign bodies, which will be published in the next few months. So I think here we end our talk tonight. And thank you all the panelists. And anyone to add on to this talk before we end it? Anyone want to put their point of view or add something to the knowledge of the audience that someone want to speak out? Please give your inputs.
So we would like to thank you. You've done an excellent moderation, and we've learned so much from you, especially the last cases. I mean, your experience with foreign bodies. So thank you, sir. We are very privileged to be part of this session.
Interventions have been my passion. I've been doing it for a long time. So whenever the intervention comes in, I just speak out. That's my problem.
No, sir, it's very interesting.
So that's but anyway, I think our objective was to give at least messages to the people who are watching this this case series or case presentation, that they may learn something out of it. And we tried to keep it as much clinical as possible. And thank you to all the panelists. Thank to the CCI Core Council, who has been really doing a great job in this academic program, which is going on for a long time. And I think thanks to everyone. And I think we should now close this session. Thank you.
Thank you. Thank you so much.
Thank you.